Welcome back, everybody. If you are just joining us, please remember that for each session, we want you to type in your name in the chat box so we can give you credit for attendance. At this time, I'd like to introduce Dr. Layla Zahedi-Spung. She is a third-year maternal fetal medicine fellow at Washington University in St. Louis. She will be starting as a maternal fetal medicine specialist with regional obstetrical consultants in Chattanooga and an instructor for the University of Tennessee Department of Obstetrics and Gynecology in 2022. Dr. Zahedi-Spung received her medical degree from Emory University. She completed her residency training in obstetrics and gynecology at Emory University and is currently completing her fellowship training at Washington University in St. Louis. Let's please welcome Dr. Spung.
Hey, good morning, everybody. Let me get my screen shared. All right, everybody see my slides?
Yes, ma'am.
Great. Thank you so much for that introduction. I know it says there are 59 slides. I promise we're not going to go through 60 slides. I will be starting with Rock in September, and I'm very excited to be joining the team. So my name is Layla Zahedi-Spung. I'm currently a third-year fellow at Washington University in St. Louis for about 3 more weeks, and I'll be talking about racial inequities in pregnancy and reproductive health care. I have no conflicts of interest. However, for one of the research studies that I may discuss at the end of the presentation, I was the recipient of the Reproductive Health Mini Sabbatical Grant through the Foundation for the Society for Maternal Fetal Medicine. So over the last several years, there's been a significant increase in the amount of information that we have regarding racial inequities and the impact that racism has on Black maternal health. So this was a study that was published and discussed by ACOG in July, talking about how racial discrimination increases stress and hampers cognitive function for Black women. We also saw that Margaret Sanger's name was taken off of Planned Parenthood in New York because of her involvement in the eugenics movement. And COVID-19 brought out our concerns about Black maternal health even worse as those disparities continued to widen during the COVID-19 pandemic and have worsened as we've continued through it. And lastly, how are we failing our Black moms, especially during the pandemic? So that should just set the stage for what I'm going to be discussing. My training in medical school and residency is punctuated by my experience at Grady Memorial Hospital, pictured here on the left, and the newer building on the right. Grady was founded in 1890 and opened in 1892. Today, it is the 5th largest public hospital and one of the busiest level 1 trauma centers in the country. While Atlanta cannot live without Grady, it has not always had such a good reputation, especially within the Black community. In the second picture, you can see the hospital appears to be shaped like an H. This is because it was built as a segregated hospital, infamously known to many older Black residents as the Gradys. The corridor in the middle was designed for all of the white male physicians to be able to traverse between the 2 hospital wings. As you can imagine, the conditions were very different between the 2 hospitals. It was desegregated in the 1960s and has been through multiple transitions since then. As a public hospital, its doors are open to all, regardless of insurance status, and therefore you can imagine the deficit with which the hospital works. It is staffed entirely by Emory and Morehouse physicians. The women I cared for during my OBGYN residency were majority Black and immigrant. I saw firsthand the impact of institutional racism that can have on a community, and despite our best efforts, the care these women received was standard of care within the bounds of our resources. Central to the discussion today is the structural racism that currently exists and has been perpetuated throughout time, ultimately affecting the quality of care that Black women receive during pregnancy. So as a caveat, I'll be focusing on the experience of Black women throughout this talk. The structural oppression that Black women experience has defined many of the inequalities we'll discuss today. This is not to discount the experiences of other women of color, immigrants, or the LGBTQ community, as many experience similar injustices. I would also be remiss if I did not mention the events that took place through the summer of 2020 as national and worldwide outcry brought attention to the travesties that occurred in the deaths of George Floyd, Breonna Taylor, and so many other countless lives. Over and over, we are reminded that this country was founded on racism and has unfortunately profited off of racism moving forward. Since having moved to St. Louis, I'm embarrassed to say I have come to even more acutely recognize my own privilege. I'm a brown woman who passes as white. I grew up in white neighborhoods and have benefited significantly from this whiteness throughout my life. I also live in the border as someone of Middle Eastern descent who has certainly experienced racism throughout my lifetime, but not anywhere close to the degree that my friends and colleagues who are Black. I'm still learning to be an anti-racist and, more importantly, unlearning what is so innately part of our society. So I ask that you correct me if you feel I need correcting. I've dedicated my life to caring for women with high-risk pregnancies, and many of these women are Black. So the learning objectives are to describe the historical context for racial inequities in the United States, discuss the impact of geography on ongoing disparities, discuss the racial inequities noted in specific pregnancy outcomes, and describe the structures of oppression that perpetuate these inequities. First, let's talk about a framework. This image here was adapted by SMFM. I'm sure many of you have seen it in different forms. So when we talk about health equity, it means that this is social justice in healthcare. So no one is denied the possibility to be healthy for belonging to a specific group, and everyone has a fair and just opportunity to be as healthy as possible. Equality would mean that everyone has the same opportunity. So they're given the same resources. However, you can see even with one block each, those who have more advantage at the beginning are still going to end up much higher, and those with the least advantage are not going to even reach the same starting point. Health equity would mean that we would provide even more resources for those women who are least advantaged in order to try and level the playing field. Health disparities are a metric we use to measure progress towards achieving health equity and how far apart are those who have health and those who are unhealthy. So a bit of historical context. In her book, Killing the Black Body, the scholar and writer Dorothy Roberts presents 3 key themes regarding the experience of Black women in the United States. The first one, regarding the history of our nation, states, regulation of reproductive decisions of Black women has been central to the racial oppression in America. Black women started their lives on our land as slaves and were brutally terrorized throughout that time period and well into modern day. This included, but was not limited to, forced breeding and childbearing, sexual abuse and exploitation at the hand of their white masters, and an inability to care for or protect their children, as any children born to a woman of a slave was the property of the slave owner. She goes on to present how the suppression and abuse of Black women continued through the use of particularly derogatory images and icons that have continued to the modern era, but in new forms. I'm sure many of these images will be familiar to you, and I'll briefly describe each of them as Dr. Roberts presents them in her introduction. These images and myths serve the distinct purpose of making it seem as though Black women are nothing more than the bearers of incurable immorality. From the birth of our country, the forefathers who helped to form the Constitution and government stated that Blacks lacked the capacity for racial thought, independence, or self-control. This allowed them to justify their use of Black men and women as slaves and the abuse that followed. Black women and mothers played a central role as they were seen to not only transmit inferior traits, but then further damage their fetuses during pregnancy due to their habits, and lastly imparted their deviant lifestyle to their children through their example. The first image is the Jezebel character, named after the biblical wife of King Ahab, and was a purely lascivious creature, one governed entirely by her erotic desires and a temptress. This served to justify white men's sexual abuse of Black women and has led to the ongoing stereotype of Black women being sexually promiscuous, which in turn makes them bad mothers. Because of this promiscuous nature, that has justified the fact that Black women require government regulation of their fertility. In contrast, Mammy was the mothering figure and embodiment of the ideal Black woman who was a loyal servant to her master and nurturing figure to the white children she cared for, while placing no value on Black women as mothers of their own children. This image went on to proliferate the idea that Black women are negligent mothers. Interestingly, in 1910, white citizens in Athens, Georgia, with the help of the chancellor of UGA, my alma mater, unfortunately, created the Black Mammy Memorial Association, which had the explicit mission of teaching Black men and women to learn to work, how to work, and to love their work that made the old Black mammy valuable and worthy. One of the most notable appearances was in Gone with the Wind, where Hattie McDaniel won an Oscar in 1939 for her memorable performance as Mammy in Gone with the Wind. The Matriarch is next. White sociologists in the 1920s and 1930s further eroded the Black female character by claiming the independence of Black women directly promoted jealousy and irresponsibility in Black men, and that this Black matriarch, which was a perpetuation of the slave legacy of unwed motherhood, was the cause of family instability. I'm sure it is not lost on any of you the irony that they are blaming Black women for their role in slavery despite their lack of choice in the matter. This idea of the deteriorating Black family has been reintroduced throughout the decades. In 1965, Daniel Moynihan, the then Assistant Secretary of Labor and Director of the Office of Policy Planning and Research under President Johnson, published a report named The Negro Family, The Case for National Action. In 1986, Bill Moyers presented a special report on CBS called The Vanishing Family, Crisis in Black America. Lastly, the welfare queen is a contemporary culmination of all of these historical images that present Black women as the lazy mother on public assistance who deliberately breeds children at the expense of taxpayers to fatten their monthly check. In a 1990 study, it was found that 78% of white Americans believed that Black women preferred to live on welfare. This is yet another example of how imagery has been utilized to justify government-mandated sterilization or contraceptive campaigns against Black women. One of the most stark examples is the handling of the cocaine epidemic compared to the opioid epidemic. The crack baby epidemic continues to perpetuate the image of Black mothers as negligent, immoral, and inept. As you can see, these headlines demonizing mothers who utilize cocaine, crack babies, the worst threat is mom herself. In response, the government threatened legal action with jail time. They also bargained with addicts to avoid jail time by being sterilized or having a long-acting implant placed in their arm for contraception, or even cutting their welfare payments. In contrast, the opioid epidemic, which has been rising for the last decade, is treated very differently, namely because the victims of this crisis are mainly white. Blame is not placed on the mother. When suggestions of criminal actions against these women were made, public outcry around brutality of that was noted. So again, these are some of the headlines that were running around the time of the crack epidemic, which never really came to fruition, obviously, as we've learned. But then, the opioid epidemic, the blame is being placed on the manufacturers of the medication. And the Trump administration even funded a $1.8 billion fund in order to try and combat that crisis. Dr. Marion Sims is touted as the father of gynecology, as he invented the vaginal speculum and pioneered surgical techniques for repairing vesicovaginal fistulas. He performed these experiments on slave women. He did this without anesthesia or ethicist, claiming Black women did not feel pain the same way as white women. 3 of these women we know today were Lucy, Anarcha, and Betsy. Given the brutal way in which he made these discoveries, there is a movement within the OBGYN community to give credit where credit is due to the women who suffered through the experimental surgeries. These women have since been named the mothers of gynecology. At this year's annual Society for Maternal Fetal Medicine conference, I had the opportunity to take part in a post-grad course about inequities in maternal outcomes from recognition to reduction, a practical skills approach with some amazing speakers. One of the key speakers is an MFM in South Carolina, Dr. Casey Eichelberger, who has done amazing work looking at the impact of geography on racial inequities. Many of the inequities we see today are entrenched in our history, much of which starts with geography. Over time, these disparities have been compounded within disparities and within even more disparities. So the next several slides are maps that Dr. Eichelberger has created to illustrate this point. So this map represents the 1860 census, demonstrating the distribution of enslaved persons across the United States. As you can see, and not surprisingly, the majority of enslaved persons resided in the Southeast and a little bit into the Midwest. Jumping forward to the 2010 census, the green dots are where Black people are living in the United States. And this distribution, as you can see, is still very similar to that 1860s census, or at least the bulk of it is. Women who self-identify as a racial or ethnic minority also live still within this space. Now, this is 2003 to 2005. This is from a 2019 study looking at where the majority of the Black population lives, and it's, almost 60% live in the South. And nationally, 1/3 of women self-identify as a member of a racial or ethnic minority, and it's estimated that that will increase to more than half by 2045. In addition, compared to white women, women of color tend to have lower incomes, are more likely to be on Medicaid, and have higher rates of illnesses, and therefore they have a lot at stake when it comes to receiving health care. I performed a study looking at the impact of Area Deprivation Index, which is a geographic, area-based measure of socioeconomic deprivation within a neighborhood, on glycemic control in our pregnant patients with type 2 diabetes. And I found that women with type 2 diabetes living in a highly deprived area, so this is an ADI map, heat map of the St. Louis area. So the deep red areas are the most deprived areas in the city, and then the dark blue are the least deprived areas. Our hospital sits right about here. And I found that women in the most deprived areas had a significant improvement in their A1C throughout pregnancy, but they couldn't actually reach their peers who lived in less deprived neighborhoods. And in addition, a sub-analysis looking at Black and white patients in each ADI cohort found that Black patients in the highly deprived neighborhoods still had worse glycemic control than their white counterparts at the beginning and conclusion of pregnancy. And this can at least in part be explained by systemic and structural racism that's plagued St. Louis. So this map on the right is the historical redlining map of St. Louis. Redlining was a widely adapted government-sanctioned practice in the 1930s following the New Deal. It provided neighborhoods with grades by certain demographics like population composition and determined whether or not banks would provide loans or businesses could open in those areas. So the red areas here were considered undesirable, and that was where the majority of the Black population lived. If you were to superimpose the ADI heat map over this redlining map, they're almost identical despite a 70-year time difference. So you can see it's had a long-lasting effect on the communities of color in St. Louis. So now that we've looked at geography, let's take a deeper dive into outcomes. Additionally, state policies regarding coverage for reproductive health services, such as family planning and abortions, have had direct impacts on meeting women's unique reproductive health needs. So first we'll look at national outcomes, and then actually we'll look at Tennessee outcomes, specific outcomes, not Missouri. Sorry about that. So this is the March of Dimes 2020 report card. It's a map of the United States, and the March of Dimes grades states by a number of different things, but more specifically looking at infant mortality and preterm birth rate. As you can see, the states in the Southeast have pretty terrible grades, right? So mostly Fs, some Ds. Tennessee is a D, Missouri is definitely a D. And runs right along that same geographic area that we looked at and where the Black population in the United States resides still. This specifically is looking at preterm birth. So again, the states with the highest rate of preterm birth are in the Southeast and the Midwest along those same geographical lines. And you can see that, Tennessee has one of the highest preterm birth rates as well. Infant mortality, which is directly connected to preterm birth weight or preterm birth and low birth weight, also is the same. So the states with the highest infant mortality are in the Southeast as well. And then Medicaid coverage. So, the states in the Southeast tend to have patients with the highest percentage of births that are covered by Medicaid. So what that says, at least in the state of Missouri, we know now that our women who are on Medicaid have a significantly increased risk of maternal mortality as well as infant mortality. So it speaks to the policies around that as well. And then just one more geographical representation. So this is preterm birth rates around the world. The United States obviously is this yellow color. It rivals countries in Africa and the Middle East for preterm birth rates. And, I think that's very stark considering how industrialized we are and how advanced we are, that we are still struggling with, making an impact on preterm birth rates. Additionally, in 2002, the CDC did a report that found foreign-born Black women have lower infant mortalities and lower rates of low birth weight and fewer preterm births than their US-born Black equivalents. This is despite having a later initiation of prenatal care. There was also a study that was done that looked at foreign-born Black women and the length of time that they had been in the United States, and found that over time, their birth outcomes worsened and never quite met, but came close to meeting those of the US-born equivalents. And this argues that there's something about the experience of being pregnant and Black in the United States that's impacting health outcomes. And I think it's fair to say that institutional racism is certainly contributing to these outcomes. So the US is the only developed country in the world with a rising maternal mortality. And according to the NIH, the US maternal mortality for 2018 was 17.4 deaths per 100,000 live births. And that was around 660 deaths in 2018. However, you can see in this graphic, the rate for Black women is 37.1, which is 2 to 3 times higher than, their white counterparts, and then the national average overall. I know in the state of Missouri, it's 5 times higher, which is terrifying. And in the United States, the leading cause of maternal death is cardiovascular compared to worldwide, where it's hemorrhage. And in addition, Black women are much more likely to have a preventable death. And for every maternal death that occurs, there have been identified at least 70 near misses. So let's talk a little bit about Tennessee. So the infant mortality is 6.9%, which is slightly higher than the national average of 6.4%. This has significantly improved from about 10 years ago when it was over 8, close to 9, based on a campaign that March of Dimes has done. But it's been pretty steady at 6.9 since that time. The Black to white ratio is 2 to 1 for infant mortality, and we've discussed, the leading causes are preterm birth and low birth weight. Tennessee received a D- from the March of Dimes for preterm birth. The overall rate is 11.2%, but it's 14.7% for Black patients and 10.3% for white patients. In addition, Tennessee's maternal mortality rate is 26.0 per 100,000 live births, so significantly higher than the national average. Black women are 3 times more likely to die, and Black women experience severe morbidity at a significantly increased risk. And the Maternal Mortality Review Committee actually found that in 2018, 100% of the deaths of Black women were preventable, which is really sad. So, what else is contributing to these inequities? So, Dr. Allison Bryant introduced an adapted version of Kilbourne's drivers of healthcare disparities. So the white circles are showing what the original were. So health system factors that overlay patient level factors and provider factors, all of which lead to a clinical encounter. Dr. Bryant added this fourth circle called structural factors. She talks about how these are things that impact the health of the population overall and also directly play into each one of these things. So, the health system, the patient, and where the providers are coming from. So why? Structures of oppression, like we've talked about, implicit bias and systemic racism, and then the quality of care. We have provider shortages. Interestingly, if you look at a physician, if physicians and patients are of the same race, specifically in the Black community, they have better outcomes. There was a study recently that looked at infant mortality and found that if preterm infants are cared for by Black preterm infants are cared for by a Black neonatologist, that they have a lower rate risk of mortality. And then this, all of this leads to something called the Black tax. And especially during COVID-19, it was doubled for patients or for these physicians and our colleagues, where they are asked to care for, Black patients because they're, scared that they feel like they're not going to get adequate care if they're not cared for by someone who looks like them, which is very sad in my mind. And then, like I said, provider shortages, especially in rural areas. So this summer, I also had the opportunity to participate in Dr. Uche Blackstock's Advancing Health Equity course through the Society for Family Planning. And she presents that structural and systemic factors drive inequity. So she presents the four eyes of oppression, which I really liked. So looking at ideology, so white patients are more likely to be compliant than Black patients, or institutional. So that would be, looking at Black maternal mortality, that it's 3 to 4 times higher than white women. Interpersonal, and this would be like a clinician refusing to call someone by their chosen pronouns. And then internalized, and this is when, because of all three of these, the community, marginalized community, actually starts to internalize these oppressive messages. So a Black person using skin lightening products. And I think some of these things cross over. So for instance, like less pain medication for Black patients is both interpersonal, institutional, and maybe even ideological, depending. So I felt like it was a fantastic framework for looking at how each level really impacts the way we care for people. There's also been a lot of conversation around implicit bias. So, we know what explicit bias is, right? That's outward racism, but that's just the tip of the iceberg. Really, the unconscious piece of it, the implicit bias, is a huge factor. These are learned from social cues that we've encountered throughout our lifetime, that those images that I discussed in the beginning, learned behaviors from family members, experiences with patients, etc. It can be as simple as the words we choose to use, like baby daddy versus father of the baby, or vernacular, or change of tone when speaking with our Black patients, to the differences in which we care for patients, even if it doesn't necessarily impact their outcomes directly. I was reminded of this recently by a mentor when I used a word to specifically describe a provider who I disagreed with that has a derogatory connotation. And while it seems simple to acknowledge it, it's much harder to truly address it. So healthcare providers are certainly not immune to this. So physicians and nurses certainly have implicit bias, and it's been shown across all specialties, although it was found that pediatricians may demonstrate lower implicit biases than other physicians in the general population. And physicians and nurses hold implicit biases against marginalized groups to a similar degree as the general population, but they tend to display less explicit bias. Healthcare providers implicitly associate Black race with an non-adherence or non-cooperation, although the literature doesn't support that. When subliminally primed with Black faces, physicians reacted more quickly for conditions stereotypically associated with Black race, like drug use, even though there's no biological association. And under time pressure, Black and Latino patients receive less serious diagnoses and are less likely to be referred to a specialist than white patients. So, pain in Black Americans is systemically undertreated and underestimated, despite them reporting lower pain thresholds and lower pain tolerance in experimental settings. There was a study conducted by UVA in 2016 that found that there remains ongoing racial bias in the treatment of pain in Black patients, and that medical students and residents truly believed that there was a biological difference in pain responses in Black patients. There was a 2019 study in the Green Journal that found that Black women reported significantly, higher pain scores, but received significantly lower amounts of pain medication by providers. So, as OBGYN at all immune to this, and unfortunately we are not. So, there certainly is bias against low SES Black and Latino women. They're perceived to be less knowledgeable, more likely to have unintended pregnancies and STDs, and more likely to be offered intrauterine devices. Black patients are more likely to undergo repeat C-sections than non-Hispanic whites. And then there's also the conversation going on right now about race in the VBAC calculator, trying to determine whether or not that is a physiologic thing that needs to be present within the calculator or not. So the original study by Dr. Grobman looked at demographic and social factors such as insurance status and marital status and race and ethnicity, and they were all found to be associated with a lower likelihood of a successful VBAC. But of those factors, only race has been included in the calculator. And so there's been a lot of discussion about removing that, because does that prime providers to move more swiftly towards a repeat C-section? During my time at Emory, the maternal mortality, and specifically the Black maternal mortality, was highlighted across the country as it is now, and was unfortunately the worst in the country at the time, coming in around 50 per 100,000 live births, which rivals Haiti. The team I worked with performed an analysis of Georgia and to determine where obstetric providers were located. And we found that over half of the counties in Georgia were without an obstetrician at all, and that the closures of labor and delivery units was significantly impacting access to care, and found that patients in these provider deserts would have to travel over 100 miles one way to access care. So this study, we created this map, took it to the Georgia legislature, and petitioned for creation of the Georgia Perinatal Quality Collaborative and the regional perinatal sites. They also secured funding to help OB provider reentry into practice and the use of midwives across the state to try and address this provider shortage. So the ultimate lesson I have found through all of my readings, research, courses, and experiences is ultimately that racism, and not race, is the contributor of these ongoing inequities. So how do we move forward? Dr. Alexis Griffin wrote a beautiful piece regarding how she's encountered racism in medicine throughout her life in the November Green Journal. She describes her journey through medicine and the racism she witnessed and experienced throughout her life. One of her quotes here was, "I'm hopeful that as we work together, we can acknowledge the role we play in the perpetuation of racism and create a medical culture in which individuals feel understood for who they are and not what they look like, a culture in which we are free from the bondage of racism." If you have an opportunity to read it, it's really a fantastic piece. So looking at racial discrimination in the United States, this was a study that looked at preterm birth rates and whether or not it was associated with chronic worry about racial discrimination. And as you can see, US-born Black women had a higher rate of preterm birth, and then in association with different types of worry. So the stress of being discriminated by clearly is having a physiologic effect. So legislation, there are several big legislative pieces right now, one of which is, looking at Medicaid expansion and knowing that the majority of deaths occur right after delivery to within 42 days following delivery, expanding Medicaid in order to provide care for these patients between their pregnancies for up to a year after birth would make a huge difference, I personally feel. And as you can see, the states on this map that have not adopted Medicaid expansion are the same states in those geography maps that I showed you before. So there are also a number of bills that are hopefully going to get heard and potentially passed. So the Preventing Maternal Deaths Act of 2018. This is a push by the CDC to help prop up and fund maternal mortality review committees, and then to also implement quality improvement initiatives. The Helping Moms or Helping Medicaid Offer Maternity Services Act of 2019 would allow for states to expand postpartum coverage under Medicaid to a year. My understanding, though, that this fiscal year's budget actually included a year of Medicaid expansion for moms, and it's up to the states to extend that care. And then the Black Maternal Health Momnibus directly addresses the inequities in Black maternal health. It was introduced in the House in July of 2020 and then referred to Committee on Health, so we're still waiting to hear about that and it moving forward. And then I'd be remiss if I didn't talk about reproductive health access and legislation. So while the government has a long-standing history of controlling Black and brown women's reproductive lives through unethical and illegal sterilization and forced contraception, until ACA, there was no support for contraceptive access. So the recent attacks on Title X clinics have led to further disparities in healthcare, as these clinics many times serve as healthcare access points for low-income women of color. In addition, ongoing attacks on abortion access aim to directly impact poor Black and brown women as well. So federal involvement. So this is the Surgeon General's call to action to address maternal mortality that was published a year ago and provided guidance for a plan to decrease maternal mortality. It's a 71-page document. Throughout the entire document, the words racism, racist, and poverty are never actually used, which I feel like if we're going to talk about how Black women have such a higher maternal mortality, we need to talk about how racism is impacting that as well. So again, how are we going to move forward as providers after this super uplifting talk? So Dr. Blackstock put together, structural competencies. So to recognize the influences of structures on patient health, recognize the influences of structures on the practice of healthcare. So for instance, like when I talked about working at Grady and that we worked within the bounds of the standard of care based on the resources we had. And then recognizing the influences of structures in the clinic. So I know at WashU, we see our Medicaid patients on a completely separate floor from our private MFM patients. And the clinic that's used for our private MFM patients is much nicer, to say the least, and just runs more smoothly. And then recognizing the influences of structures beyond the clinic. And then, structural humility, understanding that we play a role in these structures, but that there's, we are only a part of it. So suggestions for physicians, recognizing that there are certainly two medical systems in the United States, understanding that implicit bias is the result of systemic racism and not the cause, And then some concrete acts that we could put into practice. One that was suggested at that workshop that I attended was to use ICD-10 codes. So coding racial discrimination for our patients of color or exposure to poverty in order to send a signal to both the insurance companies and the hospital, which patients we're caring for and how that's impacting their healthcare. And then these are bias mitigation strategies that I, have certainly used over the last year as I've become, more in tune to my own biases. And they really, take into account the personal responsibility that we have to fight against these biases that are just innate within all of us. And then this is Dr. Blackstock's level of intervention. So what you can do as an individual, what you can do in your relationships, how you can support your institution, community, what research needs to be done, and then how policy can really be impacted as well. These are just some resources for patients. So Sacred Prem is a birth organization or an organization that is trying to support the birthing experiences of Black mothers. Loom created this really fantastic anti-racist prenatal and postnatal care preferences to support Black women when they're getting prenatal care, to ask the questions that they maybe don't always know to ask or are not empowered to. And then Sister Song is an organization out of Atlanta that supports Black birthing people. So to close, systems do not maintain themselves. Even our lack of intervention is an act of maintenance. Every structure in society is upheld by active and passive assistance of other human beings. I'm hopeful that as all of us are learning more about the role of racism in healthcare, that we can move forward and really have an impact on our health outcomes for our patients. And I would be happy to take any questions.
If you have any questions, please put them in the chat box and we will read them.
I'm happy to send my slides to Jennifer.
And we are recording the sessions and hope to have that available for viewing later on as well.
I think the only other thing, so this is my son, he's 10 weeks old now, almost 11 weeks old. When I first gave this talk, I was 36 weeks pregnant, and reflecting on my experiences as a pregnant patient while also caring for Black women, I have never once worried about dying in childbirth. I never once worried about him having a bad outcome. I never worried about me not getting the same level of care as others. There's so much privilege in being a physician, but there also, was that horrific case of the pediatric physician in, I think, Indiana, who passed away earlier this year. And I know a lot of us who were pregnant at the time really struggled with, how does someone with that much knowledge still lose their life? So I think there's a lot of humility and grace to be learned from that, and I also just am very grateful too. So yeah, I know I actually found that Tennessee has adopted Medicaid expansion, but it's not in place yet, is my understanding. So one of the questions that I had was, so there's a lot to be done interpersonally and systematically to make these necessary changes. Where did you start? And where do you suggest we start? So I think for me, kind of the penultimate moment was an experience that I had where I very clearly provided divergent care to two families who were identical, but one was Black and one was white. And I really struggled with what other harm had I done in the past as a physician in Atlanta, specifically caring for Black women. So I really just dove into the deep end. Dorothy Roberts's book, Killing the Black Body, is phenomenal. It's heavy, so be prepared if you haven't read it before, but really lays a fantastic foundation for understanding why we have these systems in place that the way they are. And then taking Dr. Blackstock's course also allowed me to kind of connect to a community of providers who are also doing the same work, so that you have support. You can't do it on your own. You're gonna falter. And it just takes time and continuing to learn and to read and to think critically about when we encounter patients, what are we coming to the table with and what are they coming to the table with? And how do I make sure that my biases don't impact how I care for them? On a local level, what is being done to truly hold clinical care professionals accountable by checking their biases and knowing how racism and not race affect Black birthing mothers? So, having not been in, Tennessee or Chattanooga yet, I can tell you here in Missouri, our department chair has taken on this specific task. So she hired a consulting group to come in to do anonymous surveys to really dive into what our clinic structure is, how our referral structure works, looking at biases within physicians, and then doing a total overhaul. So really it's been fascinating to watch her lead us through this as a very accomplished Black physician, who's also the chair of our department, trying to address all of these things. I think, supporting Black mothers having birthing coaches or doulas, what is a really great way to start, place to start. And then I know there's an organization called Tennessee, oh gosh, Healthy Start. I'll have to look it up and I can send out the resource, but they specifically are working towards equity in healthcare for Black women in Tennessee. But I think there's always opportunities for more to be done. I think some of it is we're just going to have to connect with that community a bit more. Well, thank you very much, everyone. I really appreciate the time to give this talk and your attention.
Thank you so much for your time. We truly appreciate it.
Yeah, of course. I look forward to working with all of you when I start in the fall. Do you know of anywhere to see statistics for how added labor support affect Black birthing persons' outcomes? So I don't know that there are necessarily stats, but I know that, so Loom has some really great information. So does Sacred Prem. That's specifically what they're working on, and they're partnering with departments around the country. And WashU just signed up with them, and they are specifically going into like the postpartum area of a hospital to ask about the birthing experience, to see what we can do differently. And so I know that they have a focus on birthing support for Black women, but they would be a great organization to start with. Thanks so much. Have a good day, everybody.
Thank you, you too. Our next lecture will begin at 10:15. If you would like to take a break, we will see you back at 10:15.